more and more bacteria were becoming resistant, spreading across the globe.
Very soon, we will not have enough antibiotics to treat infections.
This is a major public health problem that needs to be solved.
We need to assist each other.
We really need to do more. At CDC, we work a lot with our partners internationally to detect and respond to threats that occur in healthcare, like antibiotic resistance. One of the ways to make a difference is through using existing technology to help us think about problems differently. One of the ways we are doing this is through an app called Acumen that we are piloting in Colombia.
With the Acumen application, you have the guidelines of all the antibiotic used in the hospital and the guidelines of infection prevention and control, the contact precautions, airborne precautions, all the isolations, and the hand hygiene too.
For the patients, the best benefit of this application is to have the right antibiotic. Knowing the right antibiotic in the right time, in the right dose for the right patients, I think it makes a huge impact.
The ECHO model is another way that we're using existing technology, something that's as simple as a webcam, as a way to teach laboratorians how can we better use the microscopes and the equipment that they have to bolster their training so that we can better detect antibiotic-resistant bacteria. Because we won't be able to do anything about the bacteria if we don't know it's there.
By using virtual connectivity, 100, if not 150 participants can connect in at any one given time. We'll create a safe haven for the participants where they're able to come in on a peer-to-peer level where they feel free to ask questions amongst themselves to know how to find where the problem was and correct it so that the next time it doesn't happen again.
What CDC has recognized is that technology is really critical, but what's also really important is having that human interaction, having that mentorship and that training. We were called to assist this really large public hospital because they were seeing high rates of resistant bacteria. We were able to identify what are the major gaps that could be addressed, and importantly, how can we make those changes last over a long period of time.
We focused at 3 areas. One area was safe preparation of medication. The other part we looked at was to have the expert in infection control visiting our unit regularly to assist that IPC-ness in terms of training and supervising. But to me, even much more important is the pharmacist is monitoring medication errors, checking as to the usage of antibiotics.
The role of a clinical pharmacist is highly important to look after our antibiotics, to prescribe correctly, to control antibiotic usage in the hospital. And our goal is that no mother would take her baby home as a corpse from this unit.
Because these antibiotic-resistant bacteria are actually spreading from one person to another person, to communities, and even across borders, we all have a role to play because we all have a stake in the outcome. We really need more commitments and we really need more action. Whether you're the head of a country, the head of a hospital, or even just the head of a household, I think there are a lot of things that you can do together to effectively impact this epidemic.
Hello and welcome. Thank you all for coming here tonight. I know a lot of you have come from far and wide and even braved the sticky New York subway to be here, so thank you very much. Dr. Redfield, the CDC director, was due to be here tonight, but he's been called away urgently to the White House, so he sends his apologies. My name is Madlen Davies. I lead the global health team at the Bureau of Investigative Journalism in London. The Bureau is Britain's biggest non-profit media organisation, and we write stories and make films that are in the public interest. So for the past 3 years, we've been working on an investigative journalism project about drug resistance. My team has travelled all over the world, meeting people affected by drug-resistant infections. This time last year, I was in a hospital in Jaipur in northern India, and there I met Pinky, a young woman in a beautiful green sari. She was painting her nails a purple glittery polish when I met her, and once the polish had dried, she took me to a closed door and said, "That's where my baby Manu is being kept." As there was no window into the room, I couldn't see Manu. Manu had been in hospital for more than 2 weeks. She had an infection that was resistant to nearly every antibiotic except one, polymyxin B, which was being given intravenously. "This is the time when I'm supposed to be holding and feeding my daughter," Pinky said, "but I can't even touch her." When I left Jaipur, Pinky was praying that her daughter might live. In another part of India, we met Manoj, a father with multi-drug resistant TB. He had to take a cocktail of drugs which had severe side effects, and he was very depressed. This, coupled with the fact that none of his family would visit him for fear of catching the disease, had left him suicidal. In Malawi, we met Jelena, a young woman who just lost her child during childbirth. The wound from her C-section had become infected with resistant bacteria. Doctors couldn't quash it with antibiotics, so they were forced to surgically remove her womb. And in the UK, we met Emily. She suffered a resistant infection while she was pregnant and was forced to make a frightening decision about whether to take antibiotics that had never ever been trialed on pregnant women before. These people are just a few of the hundreds of thousands affected by AMR, and that number is set to increase if we don't act. But while the problem is vast, lots of action is happening to stem its rise. The Bureau ran a series of stories last year about colistin, one of our most precious antibiotics, which is used as a last hope to save patients' lives when all other drugs have failed. In India, as in many other countries, it was being given en masse to livestock to make them grow fatter, a practice which breeds colistin-resistant bacteria, which can go on and infect humans. Earlier this year, we had some great news. The Indian government announced it will ban the use of this drug in veterinary medicine, joining many other countries around the world. This was a formidable step, and it was made possible by a range of people working together: journalists, campaigners, lawyers, government officials, politicians, and the industry itself. And more steps are being taken. The CDC launched its AMR Challenge program last year, asking companies and organizations to make a practical pledge which would help tackle AMR. And I was really impressed with how specific these pledges were. And tonight, I'm very excited to share some of the early successes with you. In just 1 year, nearly 350 commitments have been made from organizations across 32 countries. This includes pledges from 50 US states and Washington, D.C. to take action against AMR. Almost half of the commitments focus on improving infection prevention and control. That's more than 10,000 healthcare facilities working to prevent resistant infections occurring in the first place. And I think if you're a patient, you'd really prefer just not to catch the infection rather than being treated for it. More than 45 organizations have committed to improving safe drinking water, sanitation and hygiene across the world. And that includes a $100 million commitment from World Vision to improve water and sanitation in rural healthcare facilities across Africa. Nearly half of the commitment makers focus on improving antibiotic use, which helps slow the development of resistance and protects patients from the unnecessary side effects of the drugs. Lastly, more than 55 pharmaceutical and biotech groups have committed to develop or provide access to products that will prevent and treat resistant infections. But we still need more action. To tackle the problem and to drive policy change, we need politicians and the public to truly believe it should be a priority. And for that, we need better communication about AMR. The Wellcome Trust has carried out some research on how to communicate this issue to the public in ways that it really cuts through. It's absolutely fantastic to have solid evidence to inform the way we talk about this topic, and I'm pleased that later I'll be able to share some of the practical recommendations with you. But first, here to showcase more of the successful pledges from the past year is Alex Azar, Secretary of Health and Human Services. Mr. Azar was sworn in last January. He spent the majority of his career working in senior healthcare leadership roles in both the public and private sectors. He's no stranger to the Department of Health and Human Services, having served as its General Counsel and then Deputy Secretary in the early noughties. During his time as Deputy Secretary, Azar was involved in improving the department's operations, advancing its emergency preparedness and response capabilities, advancing its global health affairs activities, and helping oversee the rollout of Medicare Part D prescription drug program. In 2007, Azar rejoined the private sector at pharmaceutical company Eli Lilly & Co. and was president of Lilly USA from 2012 to 2017. I'd like to welcome him to the stage.
Well, Madlen, thank you very much, and good evening, everyone. On behalf of the United States government, thank you all for joining me here tonight to reflect on and highlight the real progress that we have made in the fight against antimicrobial resistance in the past year. The year-long initiative that we launched last year around this time, the AMR Challenge, marks a historic step and sets a promising precedent. The success of the challenge over the past year demonstrates what's possible in the relatively short term when we have a real commitment to fight against this pressing public health threat. Since the launch of the AMR Challenge, under the leadership of the CDC last year, governments from around the globe, NGOs, pharmaceutical and biotech companies, and other private sector businesses have made nearly 350 commitments to fight AMR. I know that many of those who made that commitment are here tonight, so I want to personally thank you for stepping up to the plate. As all of you know, the United States has eagerly engaged on antimicrobial resistance, both in public and the private sector. The Trump administration has made AMR a top priority both in our global and domestic work, and the responses have been encouraging. We saw over 225 commitments to the AMR Challenge made in the United States alone, spanning organizations across all 50 states. I want to highlight a few notable examples. Of the 10,000 healthcare facilities represented by organizations committed to the challenge, I want to mention one by way of example. Premier, Inc., a large healthcare alliance of 4,000 U.S. hospitals and 175,000 medical providers. They have reduced the rate of a particular healthcare-associated infection by 46% in 500 hospitals since 2015 through coaching calls, site visits, webinars, and a new website focused on AMR. That's just one of the many healthcare providers that have taken these kinds of steps. We've also seen commitments from major food and animal organizations. McDonald's and Yum brands specifically are committing to reducing antibiotic use in the poultry and beef they use for their products. McDonald's has committed to use its market share power to reduce antibiotic use in the livestock it uses for beef products, and Yum aims to cut its antibiotic use in beef by 25% by 2025, having already made huge strides in their poultry products. For those of you who have not delved deeply into what it takes to curb antibiotic use in livestock, though I know some of you here this evening have, extending these policies to beef is a particular challenge, so we appreciate these elevated and ambitious commitments. We've also seen commitments from NGOs like World Vision, which is committing that $100 million that Madlen mentioned by 2021 in 35 countries in Africa to improve water and sanitation services in rural healthcare facilities, helping to curb the spread of antimicrobial-resistant bacteria and fungi. Finally, we've seen work from governments and the private sector together The FDA recently approved a critical drug regimen to treat drug-resistant TB, an effort that has been supported by the TB Alliance, advanced by NIH work, and benefited from the FDA's limited population pathway process. While these are certainly steps in the right direction, our work is only beginning. That's why later this year, the CDC will release its AR Threats Report, giving us a clearer picture of the significant work that is still needed to prevent resistant infections and stop the spread of germs. Continuing our fight against AMR with the same vigor we've seen over the last year will lead to lower rates of infection, lower healthcare costs, reduce human suffering, and lives saved. So this year, components of HHS, the department I run, rolled out a number of new initiatives to help revitalize the antibiotic market, increase stewardship practices, incentivize innovation and research and development, and use risk-based assessments to inform all antimicrobial use in human and animal health. For instance, the Centers for Medicare and Medicaid Services, or CMS, has developed a bundle of reforms to secure Medicare beneficiaries access to antimicrobials in the short term, while seeking to realign financial incentives to sustain innovation in this space for the long term. CMS is also now exploring implementing CDC recommendations for hospital-based antibiotic stewardship programs into the regulations that govern hospitals' conditions of participation in the Medicare program. I'm encouraged by the real progress we're making, but as I noted earlier, our work has only just begun. The real work begins again when we depart from here and return back to our home countries, whether to jobs in government or in the private sector. I'm committed to continuing this work in the coming years at HHS. One of the key elements of the vision that President Trump has for our healthcare system includes tackling impactable public health challenges. AMR is certainly a challenge where we can make an impact through better stewardship and further development of antimicrobials. But it's also the kind of issue where if we don't make an impact, a lot of other health challenges get even harder. We need commitments from all sectors to continue fighting this threat. And so, in the spirit of the AMR challenge, I want to offer a further challenge to all of you. I challenge everyone here to renew your efforts in your own world and consider what more you can do to combat AMR. On top of that, consider how you can better collaborate with other countries in this effort. We need both individual and collective action to combat the looming threat of AMR and make a lasting difference for the citizens that we represent and serve. Together, we can protect future generations from serious but avoidable losses to our health and prosperity. Thank you again for having me here tonight. Thank you all for your deep commitments to ending the scourge of AMR, and I look forward to celebrating more successes and achievements with you in the years to come. Thank you.
There's a lot of power in the way we use language. Power that can profoundly affect the way people think, feel, and act. Take this example. Would you be more willing to agree to an operation if the doctor said, "You have a 90% chance of survival," or a 10% chance of death? It's the same probability, yet not many choose the latter. So the question becomes, when we talk about antibiotic resistance, how can we ensure the language we use is effective and drives action? We tested different ways of communicating about antibiotic resistance in 7 countries, and 3 themes emerged. 1. Make it human and relevant. When we talk about who is affected and how it affects them, people are much more likely to act. For example, say everyone is affected, including you, and explain the impact on routine operations or cancer chemotherapy. 2. Make it serious but solvable. People are much more likely to take action when they feel the issue is urgent, but there is some hope. For example, highlight how antibiotic resistance will set back recent progress in health, but can be countered by developing new treatments. 3. Use simple scientific explanations. People don't want to be told what to think. They want to understand the issue. For example, use simple, clear language to explain the science. For tips on how to effectively communicate antibiotic resistance, visit welcome.ac.uk/DRI.
So the Wellcome Trust has carried out this new research on how we can communicate AMR so that it cuts through. And that research will be published in full in October, and it will be sent to you via email shortly. But I'd just like to go into more depth on the first recommendation. It's to make the problem sound serious but solvable. The research showed that to pay attention, people do need to feel that AMR is a serious problem. But to be most effective, descriptions of the problem must be combined with solutions. Otherwise, people just lose hope and switch off. Giving a clear call to action to your audience helps make it a priority for them. You might want to communicate actions and solutions, such as that we can get ahead of the problem of AMR through increasing best practices around appropriate antibiotic use. The CDC has seen a great example of work in Colombia to better control antibiotic use. A partnership with the technology company Elam saw the development of the app, Acumen. The app provides the guidelines for complex infection control, like the steps needed to stop airborne spread of microbes. Additionally, healthcare workers can use the app when making decisions about prescribing antibiotics, ensuring the right antibiotic is used at the right time and at the right dose. And next, we have Colombia's Minister of Health, Dr. Juan Uribe, who can speak to other solutions in the country. Dr. Uribe is an accomplished surgeon and has a long history of work, both in the public and private sector. Previously, he served as health director for the World Bank and for Fundación Corona, a private NGO dedicated to strengthening equity and social development in Colombia. He also led the Fundación Santa Fe de Bogotá Hospital, one of the most prestigious hospitals in Colombia. So welcome to the stage, Dr. Uribe.
So good night, and thanks so much for inviting me here and hosting me here. Secretary Azar, very nice seeing you again. Last time it was in the frontier between Colombia and Venezuela, and I want to appreciate all your support to our country. Sally, David, extremely nice to meet you. Michael, very nice seeing you as well. I want to express also my appreciation to all the artists which did such a great job around us. I had a time to look at their paintings, and their messages are extremely important. Please excuse my English. I'm thinking in Spanish and speaking in English, as you will see. So antimicrobial resistance is what I would call a public anti-good. We have public goods, as you know, but here we have a public anti-good. It really hurts all of us, and it's exactly the opposite of a vaccine. And because of that very simple fact, it's really a global challenge, and it should take the best of us out there. It goes beyond, David, the health sector, as we were talking about. It reminds us of how right the One Health concept is, and how difficult at the same time it is to be implemented. It goes far beyond the health sector, where I've spent all of my life. In Colombia, which is a middle-income country, 50 million people, we have a national plan to respond to antimicrobial resistance. It followed a lot of international guidelines, and we put it up 2 years ago. But we had many years of prior work with antibiotics and their correct use. This national plan involves the Ministry of Agriculture, it involves our National Institute of Health, it involves our FDA-like institution, the INVIMA, And we try to put all of them to work together in this big challenge. The national plan has 5 levels of intervention. The first one is the same governance of the plan, and it's not a minor one. Again, having the health ministry speaking with the Ministry of Agriculture, it doesn't happen every day, to be very frank. So it needs governance, for sure. And we need to be serious about it. You don't have that first dimension, and all the other 4 ones, which are very straightforward and very technical, will not work. So governance and management of the plan is number 1. The other 4 have to do with communication and education, and I was very impressed with the clarity and the impact of these messages. The third one has to do with surveillance and research, and I'm going to speak quickly about it a little bit more. The fourth one has to do with hygiene and prevention. And finally, we have the optimal utilization of antibiotics. Out of those 4, we've been able to make, I would say, a fair progress in surveillance and research and in the utilization of antibiotics. We work closely with CDC, by the way, and all our appreciation and recognition to their contribution to this progress. On surveillance and research, we have a report system. We have an information system that captures everything that happens in public health in Colombia, and it's pretty good, by the way. And antimicrobial resistance is one of those factors that we're capturing in our information system. And that means a lot for epidemiological research and for proper public policy in the future. Second, and as you saw in the video, we're working in resistance in hospital settings. So we go to the intensive care units, the NICUs, those spaces in high complexity hospitals where this can be one of the biggest challenges, if not the biggest, and we do research on what's happening to us. And I'm not an expert on microbiology or antibiotics, but we can clearly identify which are the elements that are posing the biggest threat to us, which are the antibiotics which are in a way showing resistance or showing effect, and we can know in a pretty good way in those hospital settings what our challenges are. We also have, as you saw, a software that helps us keep all this information put together, and we've invested in improving our public health labs, which is extremely important. We have a very solid national public health lab, but we need the lab's capacity at the subnational level. In a big country, again, with a lot of cities, a lot of things going on at the same time, it's the whole system that needs to be strengthened. Moving from the surveillance and research to the optimal utilization of antibiotics, we've followed the best practices and the best evidence in terms of diagnosis and treatment and what the proper guidelines of utilization of antibiotics are. We have an industry that has agreed on a self-regulation, which helps and pushes in the right way. And more important, we try to enforce controls on the sales of antibiotics. They're not out of the shelf. You need to have a formula. The formula needs to be official. They can track back who is selling what antibiotics to whom. That's something that happens, and that's, again, proper. However, and this is my second half of these short words, and quickly, I was again talking to David, who was telling me how does it happen in Colombia, and I was telling him, when you go to Bogota, Cali, or Medellin, like when you go to Lima, or Buenos Aires, or Sao Paulo, or to Mexico City, and you go to solid institutions, to big hospitals with I would say a lot of sophistication, antibiotic use is really solid and proper. There's clinical governance. The physicians have self-control. They're accountable. There's review. There's peer review. So it works pretty well. However, when you look at this challenge, you need to consider that middle-income countries and low-income countries are extremely disparate. The performance variability. You will find institutions as good as the best in the US, but then you will find these places of inequality and poverty concentrated, where there's really very limited presence of the state and very limited organizational capacity. So for me, when we're talking globally, Sally, when we're talking about the antimicrobial resistance globally, it's those pockets where of our collaboration. These are places where the most basic inputs and resources are needed, where infrastructure is not yet there, where human resources are struggling, doing their best effort with bare hands, where many times knowledge is not available in the right time, where many right reasons, there's many other needs, where policies do not exist and where leadership is struggling. I do believe that it's for those places, for those pockets, again, in this anti-public good, that we need to put the best of our efforts. And I would just conclude recognizing and appreciating the effort of antimicrobial resistance. Thanks so much.
Globally for public health. Everybody out there. One Health is the idea that humans within the environment every day, we all interact with each other, we go home and interact with our pets, we're eating food from the animals that are being produced on the farm.
The antimicrobial resistant infections can spread between people and animals.
That to us is exactly why it's important that we work with stakeholders and partners across the pet care community on antimicrobial resistance.
We all need to move the needle forward together through collaborations. That's why our partnerships are so important.
The Centers for Disease Control on all aspects of the pet care community, from breeders and distributors of animals to food and product. We look at the sanitation that's used to keep clean environments. We look at transportation protocols, and we also make sure that people working with animals take steps diseases before they even enter into the equation to minimize the risk of antimicrobial resistance developing.
Both to make sure that we have strong policies to prevent antimicrobial resistance, but also to ensure we have the right education around that relationship between pets and people. Not only do we not sell any antibiotics over the counter, we also do not allow any prophylactic use, both in our stores or from animals that are coming from any sort of vendor. We put those in animal health in our stores and from the supply chain, but making sure that as a company we are being as proactive as possible to protect human health and public health, because we can never forget that these are going to be folks' pets living in the house with their family, and we want everybody in that entire family very healthy.
We all live in one world together. What we do impacts the animals around us. What the animals around us do impact us.
If you make great strides, for instance, on the human side in healthcare, if those same strides aren't made on the animal side, then it's going to set us back.
The biggest strides we're going to make is the entire industry coming together to address these issues so that pets can continue to be an important part of our lives and enrich everything that we do.
Now I'd like to share with you the second recommendation for effective communication around AMR, which is to use simple scientific explanations. The Wellcome Trust's research showed that people don't want to be told what to think, but they do want to understand the issue for themselves and come to their own conclusions. So providing at least a basic understanding of AMR is necessary to make people prioritize the issue, while also preventing misconceptions about how resistance response. But we need to make sure that our explanations are sufficiently clear and accessible for our audience. We really don't just want to be speaking to people already interested in science here. Like this. The bacteria that cause illnesses adapt and change over time, meaning they can develop the ability to defeat the antibiotics designed to kill them. Our overuse of antibiotics is speeding up this process. The result is that antibiotics are becoming less effective. The videos you'll see tonight and the art around the room from CDC, Wellcome Trust, American Society for Microbiology, and the AMR Fighter Coalition are great examples of making important technical work more relatable without completely losing the science. But to help us show the human face of AMR, we desperately need more patients to tell their stories. I've interviewed our next speaker before, and I know firsthand that his story, his bravery, and his drive really are quite remarkable. Stage, Mr. David Ricci. Mr. Ricci is a survivor of a drug-resistant infection that nearly took his life. His experience inspired him to become a campaigner on AMR, and he has traveled to Washington, D.C. regularly to lobby for stronger regulation to combat the problem. He now works for the Institute for Systems Biology and their AMR 360 campaign to educate youth about AMR. Welcome to the stage, Mr. Ricci.
Hello. Excuse me, my throat's a little stiff tonight. So my name is David Mateo Ricci. It's okay, my uncle says the same thing and we debate about it. So in 2011, I was working at an HIV clinic in Calcutta, India, which was one of the best things I've ever done in my life. I really got to see the human impact of what health is. Walking to the orphanage I was working at, and I was hit by a train and run over. And so that resulted in the brutal amputation of my right leg above the knee without. And it was very traumatic. If you'd like to see it, it's kind of cool. But that's the human aspect of this, right? Because I'm here to show you what happens when AMR affects us personally. And, you know, months, which, as she mentioned, is the last resort antibiotic that we have. And without that, there's really nothing left. And microbes are evolving resistance even to this. The first documented case was the same year I was hit in 2011. You know, being on colistin is the worst thing that's ever happened to me. It was worse than getting hit by a train. And when you're on for 2 weeks at a time because it's so lethal and toxic. It's one of our oldest antibiotics from the 50s, and we shelved it because it was killing patients faster than the infection. It wipes out your immune system, it kills your kidneys, and every single day I was throwing up. I lost over 80 pounds. It feels like your organs are disintegrating and rubbing against each other. I was just in constant pain because of it. And after I was sent home from the hospital after about a month, I continued using IV antibiotics for 6 months. And, you know, it is a privilege for me to be here because, not only because of the color of my skin and the country of where I'm from, but most people who suffer from this go undiagnosed in China and India. And they are left out of this entire discussion, and they're not here on stage. And most of them, as I said, you know, the hospital report says they died of a liver infection or something else. And I think the greatest thing we need to do is say, it isn't because doctors are irresponsible with antibiotics, although that is part of it. You know, some statistics put it out agriculture, and that's kind of a hot topic for people not to mention. But over 70% of the antibiotics that are developed go to agriculture. And the way that we develop meat in this country is disgusting. It really is. It's unnatural and it hasn't been done for 10,000 years, but just in this century, we congregate animals into buildings about this size, thousands of animals, no sunlight, and we give them prophylactic antibiotics, hoping that, because of their wretched conditions, living in their own fecal matter, biting each other. An average cow's lifespan is 20 years, but here it's 4. And these are mammals just like us. They have memories and pain just like us. And in many countries, like in India and in Chile, they use colistin prophylactic. The last resort antibiotic we have. And again, colistin is disgusting. It kills animals using colistin just before there is any infection. That's what causes AMR to evolve. That's what creates it. So we are actively creating it while we profess our grandiose schemes for combating resistance. And all of you have much more influence and knowledge about this than I, and so I urge you to please reevaluate. Spared from this as well, because where's all that manure going from all these animals that are pumped full of antibiotics? We use that manure to then propagate crops, to grow corn and the rest of our food. Antibiotics are found everywhere now, and it's in our water, it's everywhere. And I don't want to scare everyone and just talk about negative things, because there is a lot of hope. And that's why I'm here. I'm very hopeful. And this subject is so inclusive to so many issues. That's why I've dedicated the rest of my life to cause a lot of subjects that the general public can wrap their head around, but this is not one of them. Because as soon as you start talking about enzymes and evolution and mutations, you lose most of the public. And so for me, I find just being honest is the best way to start, not just to give all of these, happy connotations to what we're doing with what we've been doing. And, diversifying our use of antibiotics as well. There hasn't really been a new class of antibiotics since the 80s. And that's because there's not really an incentive. Not wanting to invest $3 billion into an antibiotic, because by definition, you're only hopefully going to use it once and for 3 weeks, whereas there's much more profit to be made in cancer and in chronic illnesses that require drug companies to make a revenue on a monthly basis off of the patients. And part of this, I'm blessed. They might not have found out they have an infection. And, I don't also want this to be a discouragement from people traveling the world. People are like, well, yeah, you went to India, what do you expect? Of course, there's lots of infections there and massive poverty. Us from traveling. If anything, it's to show that, it happens here too. It happens anywhere. It's happened in hospitals here. And if we don't stop this, it will get worse. And our futures are at risk. Our children's futures are at risk. My life is at risk because of this. This isn't because the bacteria just randomly mutated. It's because there's a pressure for selection against this. And so I challenge all of you to, in your daily lives, be more conscious of what you eat, whether it's plants or meat, just to be aware that it's not raised with antibiotics. And, Secretary, there are chicken nuggets and other things not to be used with antibiotics, but that's only in America, right? McDonald's serves the rest of the world in American countries. And so educating our youth is really important to me. And people before they get to the graduate and undergraduate levels, so that way high schoolers and younger can understand AMR, because it's not a complicated subject. It's the way that a lot of times professionals have talked about it. It complicates the issue a bit. So read up on this and to, if you know about it, educate your family members and younger people. Even if they're not interested, try and take a minute of their time, because all of our lives are in danger. It's not, it's all of us. And, you know, just like with climate change, those that are well off won't see the effect immediately. And so, but it will happen. It will happen here too, rampantly in all of our hospitals. Jim O'Neill, a UK British economist, has mentioned that potentially by 2050, over 10 million people a year will die from AMR. That's more than cancer, and the cost will be over $100 trillion. So that should be an economic incentive enough for us to make a change. Some people have disputed that figure. I would say it's probably likely a lot higher because the statistics just aren't there. I met with the Deputy Commissioner of the FDA, and their biggest thing was they don't have enough data to make implementation changes. And, you know, the FDA asks permission for these factory farms before they can go in, months in advance. So they change their procedures, they change the quality of their prophylactic antibiotic use. A lot of times veterinarians don't even need prescriptions to give the animals mass antibiotics. So that's what I'm most passionate about. That's what I think we need to change the most. So thank you for your time.
Never heard of a young, healthy person getting C. diff. I've been a nurse 20 years. I had never heard of that. She just got sick so fast and she was gone.
I did not know I had XDR-TB for the first 6 months. I was popping over 20 pills a day for over 2.5 years, 6 months of daily injections. I can't even count what happened to me. There was jaundice. I lost my eyesight for a while.
I had just turned 26, and this happened 2 weeks after my wedding as well. So it was infection after infection after infection. I was diagnosed with MRSA.
Collectively, I think, failing this world in terms of resistance to antibiotics and in terms of drug resistance.
We need to get into the back, into our communities. We need to go to the grassroots and talk to the community and tell them, let them know.
People into preventing infections, diagnosing better, and actually looking after our antibiotics. And to do that, we need a face.
Social change. So I have decided to take action and to sing about resistance because it has made my family smaller than it used to be. And I don't want to lose any more people in my family, in my neighborhood, in my country, in my continent, or anywhere in the world. Yeah, man. And that's exactly what we do.
So I'd just like to share with you the third recommendation for effective AMR communication. As we saw with Mr. Ricci's speech, make it human and make it relevant. The Wellcome Trust research showed that for communications to be effective, we need to show the human impact of AMR. explaining how people are affected rather than relying on numbers and statistics. We should link to diseases and procedures that will resonate most with our audience. For example, the research showed that in India, this might be about how AMR will affect TB. In Kenya, it was understood through its impact on malaria eradication. And in the UK, people responded best to how it could impact cancer treatment. To strengthen our communication even further, we should explain how AMR could directly affect everyone, but this effect is enhanced if we combine the idea of everyone with a personal angle. AMR will affect you, we need to say. You, your friends, your family. This has the potential to transform perceptions of AMR from an issue that's important but far away to one that requires you to make it a priority. The World Health Organization has really led the way on raising the profile of AMR, making this the first pillar of each country's global action plan and hosting a World Antibiotic Awareness Week every year. We have a World Health Organization speaker next who can tell us more. I'll soon be welcoming to the stage Dr. Poonam Singh, World Health Organization Regional Director for Southeast Asia. Dr. Singh became the Regional Director in 2014, and she was the first ever woman to hold that role. Previously, she was the Health Secretary for the state of Punjab, which has a population of 27 million. She's also worked in healthcare-focused roles for the World Bank and as an international health advisor to the Indian government. During her time at World Health Organization, she's been committed to combating drug resistance so that progress made on prevalent diseases like tuberculosis is not undermined. Welcome, Dr. Singh.
As we've gathered here in New York this time to talk about universal health coverage, and I come from a meeting where we were discussing that, I wondered really why AMR was not on the agenda there, because in various panels that I've been in, I have not seen AMR being discussed. So I thank the organizers of this event for having provided this platform for a discussion on AMR. As far as AMR is concerned in the Southeast Asia region of WHO, we have been giving it a priority since 2011, far back before the world really started talking about it. In 2011, ministers of our region met in Jaipur, India, to deliberate on AMR, and there was a ministerial declaration on AMR. That became the basis of work on AMR in our region. After that, we had a follow-up action on the ministerial declaration. Very often we are criticized and we are told that we are easy with declarations, we adopt resolutions in the World Health Assembly, but there's no follow-up really. Do we really see that there's progress on what we have decided? There's action taken on what has really been adopted by the member states of the World Health Assembly? Therefore, in 2014, we again had a meeting in Jaipur to see where we were with the AMR. In 2015, the World Health Assembly adopted a global action plan on AMR, and member states of the Southeast Asia region were in the forefront to have national action plans on AMR. And not only that, we are reviewing that continuously to see what is the progress on AMR. We do find that, yes, the animal sector, the agriculture sector, and the human sector have come together, but of course, not the way we would have liked to. We do have the One Health approach. Member countries of our region are looking at it. We in the Southeast Asia region are advocating for it, constantly monitoring it to see where the damage is the most. And as has been said by many speakers before me, it's the animal sector, the ecosystem that we need to really be looking at. A few days ago, a patient was detected in India with a bacteria which we only find in the ICUs of hospitals. And that got us thinking that how was it that Klebsiella could be found in a patient, in a citizen who'd never really been to a hospital. And we discovered that that was because of waste disposal that was happening in the hospitals. Waste disposal really hasn't been addressed the way it should have been addressed, the way it ought to be addressed. So today, ladies and gentlemen, the threat for AMR is far more than we would like to believe. Today, what was in the ICUs of hospitals is out in the open. And we are having vegetables grown in that soil, we are having fruits grown in that soil, and that is how the danger from AMR is getting really spread all over. We've tried to see how we could support, how WHO could support member states in trying to deal with this. We've tried to expand our laboratory networks, we've tried to build capacity in member states to be able to detect AMR and be able to see how they could contribute to the control of AMR. Now, we do realize that there are many countries of our region where drugs can be obtained over the counter, and these are not really against a prescription. So the dangers that are faced by the developing world are far more than we face here, because there, even though there may be laws that do prescribe, and now it's happening in several countries of my region, where the law is talking about prescriptive drugs, there's no real enforcement, there's no regulation, and even today we can go and get these drugs across the counter. I also feel that there is a lack of awareness among those who prescribe drugs. They do prescribe drugs without understanding that it's going to build resistance in a patient. We find that, yes, antibiotics, which should be taken 5 to 7 days actually, are taken for 3 days even today, and the doctors there also need to be made aware of this when they are prescribing these antibiotics. So the problem is far more than we would like to believe. It is something that we are aware of, which we are trying to deal with. How far successful we're going to be with it, we cannot say, because even in hospitals, the best of hospitals today, I find that it's very customary to give drugs which really should not be given. The speaker before me was referring to colistin, and I've seen that being prescribed in some of the best hospitals in our country when they should not really be given at that stage, and that's how we are compounding the problem and building this more and more. We therefore need to do a lot of things to be able to handle AMR. We need to build awareness not only among the populations so that they understand that if something has worked for them when they were ill at one stage of time, it's not necessary that they should take the same antibiotic when they have a problem that they'd had before. And I find this a very common feature there. We also need to educate those who have to prescribe drugs. They have to be very careful about what they prescribe. They have to be very careful about the length for which they prescribe them, because that also becomes a very major issue. When they prescribe something, patients feel they can take them for just 3 days and that's enough. And that's a very common feeling, not only among the cities or the rural areas, but all over. And we also need to see that governments get into action, that governments see that, yes, they bring in regulatory forces, that there is enough regulation to see that there's not over-the-counter sale of drugs without prescription, that there is sufficient awareness among those who need to be aware of AMR developing if they take drugs that are not needed. And I do believe that the World Health Organization is trying to do its very best for it. We have started a lot of initiatives where we think we'll be able to help the governments of our countries in handling AMR. The One Health approach is a good example of it, where the three organizations, the OIE, the FAO, and WHO have come together to be able to advocate against AMR, yet a lot remains to be done. And as we proceed with doing what we already have adopted in the national action plans, and as we continue to help governments, and as we start helping the countries, the people of our countries, we still find that there are huge gaps which we need to fill before the world really can be safe, and before we really can say that the problem of AMR is handled. We have a long way to go. And there are all our stakeholders, all our partners should be playing really a very major role and are doing that. Yet the problem is so challenging that it needs a lot of effort to be able to handle that. My urge and my request really, and what I really urge those present here, is to see that AMR shouldn't be just in the preamble of the SDGs. It should really have a place in the SDGs. It should figure there, because the problem is so acute that unless it's given that kind of visibility and unless it's monitored year after year when we meet for UHC, we will not be able to handle it. One of the main components of UHC, and when we are talking of leaving no one behind, and when we are talking of reaching all, what is it that we are really talking about? We are talking about access to medicines. We are talking about reaching one and all when they need health care and when they need medicines. But if these medicines really are going to then lead to a bigger problem, that is where we need to be cautious. When Alexander Fleming discovered penicillin, the world went crazy. We all thought it was a great discovery. Just see how soon we are discussing resistance from those medicines, resistance from antibiotics. And that itself is food for thought. We should be getting together and thinking what was considered to be a boon not very long ago is considered to be a major threat today. And that, ladies and gentlemen, is important for us to give it more thought, and for us to think, what are the ways in which we can deal with this problem? Thank you.
Beginning of the antibiotic era, there's been this parallel story of misusing antibiotics in agriculture, of giving antibiotics to animals that are not sick, that do not need them.
Antimicrobial resistance is a global crisis.
The problem of antimicrobial resistance has reached alarming levels.
Extensively drug resistance to tuberculosis has been identified in 105 countries.
This is Armageddon. This is the end of our current regime of antibiotics.
If we don't do something about antimicrobial resistance, in another 35 years, there could be 10 million people a year dying. The policymakers only move when the tsunami is there.
And I do worry about that. I lose sleep about it.
It's important to not walk away from the battlefield.
If we truly lost all our antibiotics, it would be a bomb blowing up our healthcare systems around the world.
So as I've mentioned previously, the full findings from the AMR communications research by the Wellcome Trust will be published in October, and it'll be sent to your inboxes. But in the meantime, I really hope you take 3 top tips away with you today and start to adopt them during your communications about superbugs. 1, make it serious but solvable. 2, use simple scientific explanations. 3, make it human and make it relevant. The CDC's AMR Challenge Year shows us what's possible when we all step up, when we all partner, when we all commit to taking meaningful action against antibiotic resistance. But while we celebrate the end of a successful year, and there's certainly a lot to celebrate, the work is not done. Most of you are in New York here to talk about universal health coverage, the right of every person to health care without facing financial hardship. But AMR is a shining example of health inequality. Millions of people every year die of treatable infections because they have no access to the antibiotics they need or they can't afford them. Meanwhile, overuse of the drugs has fueled rising resistance rates. So countries now face a two-headed monster: lack of access to antibiotics and antibiotic resistance. AMR creates a vicious cycle because as resistance rises, it limits the pool of effective antibiotics available. By the time we improve universal health coverage, by the time we improve access to antibiotics for the poor, they may no longer work. And new drugs are likely to be expensive and out of reach of the global south, unless we come up with better ways of financing drug development. So I hope in any further meetings you have this week and back at home, you'll include AMR in your discussions about universal health coverage. And I hope tonight will inspire you to make a pledge or continue with a pledge and to continue fighting. I think you can see that what we do in this room matters and we can make a difference. So it's with great pleasure now that I'm going to introduce a fellow Brit to the stage. Dame Sally Davies has been England's Chief Medical Officer for 9 years. During that time, she's been a passionate and outspoken campaigner on AMR and has massively raised its profile internationally, resulting in a UN resolution in 2016, which was a huge accomplishment. She subsequently became co-convener of the United Nations Interagency Group on AMR, and helped establish the $265 million Fleming Fund to develop laboratories and surveillance for AMR across the world. Though she's now stepping down as England's Chief Medical Officer and will start her new role as Master of Trinity College, Cambridge next month, I know she'll carry on tirelessly campaigning as UN Special Envoy on superbugs, and I hope she's just as outspoken. Welcome to the stage, Dame Sally Davies.
Thank you very much, Madlen. Those stories you brought us from around the world made AMR real. David, you brought the story alive in the way that only a person who's suffered has. I came to this actually through my medicine as a doctor, a hematologist, looking after patients, sickle cell disease children getting infections that we couldn't treat. And I've seen people suffer, I've seen people die. I don't like it. Still, let's talk about the good bit. We've made lots of progress, and I think this evening is a celebration of progress. I also have a personal celebration. When I talk about pets in England, they tell me to talk about companion animals. It was lovely to hear you in America talk about pets. That, for me, was another high point this evening. The film that you've just seen a clip from, and I hope you're going to stay and watch with us, is the Antimicrobial Resistance Fighters film. And I was talking with Gary from the Antimicrobial Resistant Fighters Coalition, who do this wonderful program. You saw some of us, our pictures and us speaking about it all around the world. It is a fantastic program. And I said, you know what? We need to get this film seen by people. because I know a lot about this subject, but I learnt things. And actually, it really got me. I felt renewed in my determination to go on working to make a change, make it better. So here we are, and I want you to watch it. But let's just for a moment think about the other artwork that's here. In wandering around earlier, I was terrifically impressed by it. Of course, I rather like the 50 Shades of AMR over here, because I seem to spend rather a lot of time trying to explain, not only to the public, but to doctors, that funnily enough, bugs can give their resistant genes over to another one. And I've described it in all sorts of ways. I've even described it as putting out a prick and passing it along. But that picture shows it beautifully. There are other wonderful ones, and you've all been wandering around thinking about which you like most. The surgeon's comic set against an antibiotic apocalypse, or the Ghana AMR dance. All these things where people are bringing the issues to life, and in doing so, bringing others into this fight for life, fight for what we need to do. So, what we really want you to do is sign up to the Antimicrobial Resistant Fighters Coalition, stay and watch the film, and then, of course, we've got to think about what we're going to do in the next year. We've got to renew our pledges. When I came last year, and thank you CDC, Health and Human Services, and the rest of you, the Wellcome Trust, who put this event on, I promised to myself, I'm not very good at writing these things down, that I would go on with renewed energy. I can see I'm going to go away again and reflect even more strongly on how I can use my new special envoy role to help this fight against bugs that do seem to want to win. And remembering that actually bugs are our best friends as well. Otto Kars, who's in the audience, who's really a wonderful microbiologist, explains it much better than me, how more than half our cells on our bodies are microbes, and they are there to help us, to go on life's journey with us. We need to find a balance to continue on that journey with our friends, as I call mine, and yet reduce resistance and the illnesses and suffering that comes with it. So, I've felt inspired by all that I've seen, all I've heard. You must be awfully boring if you haven't been inspired as well. I think you probably have, and I hope you're going to stay and watch the film, because I thought it was gripping when I went and saw the full film in Copenhagen, and they've shortened it specially for us. What I need to ask is, are we moving straight on to the film, or are we letting people have a comfort break? Comfort break. A comfort break means you can look at this or have a pee. It does not mean you can walk out of the door. If you do walk out of the door, you're missing a great film that you'll want to talk about. So see you in 10 minutes to watch the film.